Wednesday morning, 6:52 a.m. I'm scrubbing in for my second surgery of the day. The patient is 67 years old. His name is Donald. Donald had been told for 4 years that his kidneys were fine. Routine blood work, normal range, nothing to worry about. His doctor said it every single visit. But 2 weeks ago, his labs came back different. Creatinine up, eGFR dropping fast. And now I'm standing here looking at what 4 years of silent damage actually looks like. The kidneys are pale, slightly enlarged. The tissue doesn't have that healthy deep red color I look for. What I'm seeing started years before anyone thought to look for it. Not one day of pain, not a single warning Donald noticed. That's the thing about this organ. It does not ask for help until it has already lost a significant fraction of what it had. My name is Dr. Richard Caldwell, bariatric surgeon. 30 years in the operating room, over 3,000 procedures. And today, I need to talk about the organ that obesity destroys first, and most quietly. The kidneys. 2 fist-sized organs sitting behind your abdominal cavity, filtering your entire blood supply around the clock. They have almost no pain receptors on their outer surface. They cannot alert you when damage is accumulating. By the time they finally do send a signal, that signal is a lab result your doctor looks at and says, let's watch this. Watch this. 2 years of watching. Meanwhile, the damage compounds. There is something on my desk right now, something ordinary, that connects directly to your kidneys and to what I'm going to tell you at the end of this video. Hold that thought. Before we go anywhere else, I need to say something directly. If you are carrying extra weight, if obesity has been part of your life for years, what I'm about to describe is not your fault. The food industry, decades of wrong dietary advice, a healthcare system designed around treatment rather than prevention, they all played a role. You did not choose this biology. What I'm giving you today is information. Specific, measurable, actionable information about what is happening inside your kidneys right now, because the moment you understand the mechanism, you have the power to interrupt it. Most people believe kidney disease happens to people who ignored diabetes for 20 years, or drank heavily, or had some obvious announced risk factor. Here is what those people were never told. Obesity is an independent risk factor for chronic kidney disease, entirely on its own, without diabetes, without hypertension, without any other condition added. And it works through a mechanism that barely gets mentioned in a standard checkup. It is called glomerular hyperfiltration. This is what I need you to understand before we talk about the 5 signs. Your kidneys contain approximately 1 million tiny filtering units called nephrons. The number of nephrons you have is fixed at birth. You cannot grow new ones and cannot replace the ones that scar over. When you gain significant weight, your body has more metabolic demands, more blood volume, more waste to filter. Your kidneys respond by pushing each nephron harder. The glomerular filtration rate goes up. This sounds like compensation. For a while, it is. But years of sustained hyperfiltration wear those tiny capillaries down. The connective tissue thickens. The filter scars over. This is called glomerulosclerosis. And once a nephron is gone, it is gone permanently. A 2025 review confirmed that approximately 10% of patients with obesity-related kidney disease progress to end-stage renal disease within just 6.2 years of diagnosis. End-stage, dialysis, and most of them had no idea anything was wrong until it was already far advanced. Sign number 1. Your blood pressure has been creeping up, and nobody connected it to your kidneys. Not a dramatic spike. A slow, quiet increase year over year. 130, then 136, then 143. Your doctor adjusts the medication. Everybody moves on. Here is what is actually happening beneath that number. Visceral fat, the deep abdominal fat that accumulates with obesity, physically compresses the entry point where blood vessels feed into each kidney. The kidney reads that compression as a low blood flow emergency. It responds by activating the renin-angiotensin-aldosterone system, the RAS, a hormonal pressure system designed to raise blood flow in a crisis. In obesity, this system gets chronically overactivated by a false emergency signal that never turns off. Your blood pressure rises. That elevated pressure then drives more glomerular hyperfiltration inside running the very kidneys. For years, medication lowers the downstream number. It does not remove the fat pressing against the kidney entry point. That distinction matters enormously. Sign number 1 is blood pressure that keeps requiring adjustment while the underlying cause remains untouched. Sign number 2. Your ankles and feet swell by the end of the day. and you have been calling it being on your feet too long. You notice it every evening. Shoes feel tight, a visible indentation when you press your finger into the top of your foot. You elevate your legs, it improves overnight. You repeat this every day and assume it is circulation. When glomerular filtration begins to decline, the kidneys become less efficient at excreting sodium. Sodium retains water. That excess fluid pools in the body's lowest points, the ankles, the feet, the lower legs. This is peripheral edema, but here is the detail most people miss. Check your face in the mirror first thing in the morning before getting up. Puffiness around the eyes, combined with ankle edema that worsens through the day, is not a circulation problem. That is your kidneys communicating through the only language they have. Sign number 2. Sign number 3. You are getting up 2 or 3 times a night to urinate, and you have been told it is your prostate or your bladder. 3 in the morning, you wake up again. You have been doing this for so long, it feels like just part of getting older. The urologist found nothing. The bladder scan was normal. Nobody ordered a kidney function panel. When kidneys begin losing their ability to concentrate urine during sleep, a process requiring intact tubular function, the body produces more dilute urine at night instead of efficiently concentrating it. The medical term is nocturia. The tubules fine-tune urine composition after filtration. When hyperfiltration damages the glomerulus, the tubules suffer next. The earliest functional sign of tubular injury is the loss of overnight urine concentration. Nocturia in an obese adult over 60 is a kidney problem at least as often as it is a urological one. Sign number 3. Sign number 4. Your blood work says your kidneys are normal, but you have never had your urine tested for protein. This is the one that makes me genuinely frustrated as a physician, because it is a systemic gap in standard care that is completely correctable and almost universally not corrected. A standard blood panel measures creatinine and calculates eGFR, estimated glomerular filtration rate. This tells you what capacity remains. But in obesity-related kidney disease, glomerular hyperfiltration keeps the eGFR reading artificially normal for years, sometimes decades, while architectural damage accumulates inside the nephrons. Your kidneys are working overtime to maintain a normal-looking number on a blood test. The compensation itself masks the injury, and the standard panel never catches what is happening underneath. The test that catches it earlier is a simple urine test. Albumin is a protein that normally stays on the blood side of the filtration barrier. When the glomerulus is under hyperfiltration stress, that barrier becomes slightly leaky and small amounts of albumin spill into the urine. You cannot see it. There is no foam in the toilet. Not yet. But a urine albumin to creatinine ratio test catches this years before eGFR starts dropping. That is the test that changes the timeline. A 2025 review confirmed that microalbuminuria is the earliest clinical sign of obesity-related kidney disease, and most patients over 60 with obesity have never had this test. Not because their doctor is careless, because it is not on the standard annual panel. You have to ask for it specifically. Urine albumin to creatinine ratio. Write those words down before your next appointment. That is sign number 4, telling you the most important test you haven't had yet. Sign number 5. You feel chronically tired, mildly nauseated after larger meals, and your concentration has gotten worse over the past year. And every single symptom has been attributed to your age. This cluster has a name in nephrology. Uremic symptoms. Uremia, the buildup of waste products that healthy kidneys clear continuously, in early kidney disease produces a low-grade, constant biological interference. Low-grade uremia causes fatigue that does not respond to sleep. It is cellular-level exhaustion. Your cells operating in a slightly toxic environment around the clock. It causes nausea, particularly after protein-rich meals, because protein metabolism generates waste products that impaired kidneys cannot fully clear. And it causes cognitive effects, mild difficulty concentrating, mental fog, word-finding pauses, all of which sound exactly like normal aging, all of which have a biochemical explanation that a standard checkup is not looking for. A 2023 U.S. study tracking obesity-related CKD mortality found the age-adjusted death rate increased steadily from 2018 to 2023. That trajectory is accelerating precisely because this symptom cluster keeps getting dismissed as normal aging, tired, foggy, mildly nauseated after meals. That is sign number 5. And now I need to come back to what I mentioned at the beginning. The ordinary thing on my desk. It is a glass of water. Your kidneys filter the equivalent of 200 liters of fluid every single day. Every minute, about 1.2 liters of blood silently moves through the renal filtrations without complaint and gives almost no warning until a significant fraction of its capacity is already gone. Chronic mild dehydration, which most Americans over 60 experience daily without realizing it, forces each nephron to work harder to achieve the same clearance. In a system already under hyperfiltration stress, that is adding load to a machine already at capacity. 8 glasses of water a day is not a cliché. For someone with early kidney stress from obesity, it is one of the few genuinely protective steps available today. Without a prescription, that glass of water, drink it, then drink another one. Let me tell you about a patient I will call Raymond, 72 years old, retired firefighter, significant weight since his early 50s. His blood work showed normal creatinine for years. His doctor told him every visit, "Kidneys look fine, Raymond." His ankles had been swelling since 68, getting up twice a night since 69, fatigued and foggy since 70, all attributed to his age and his career. He came to me for a bariatric consultation at 72. I ordered a urine albumin to creatinine ratio. His result came back at 142 mg/J, significantly elevated. His eGFR was still technically normal, but his kidneys were leaking protein at a rate that meant serious glomerular damage was already underway and had been for years. Raymond had his procedure. 18 months later, his ACR was down to 31 mg/J, back in the normal range. His nighttime urination dropped. His ankle swelling resolved. His nephrologist used a word I want you to remember: reversed, not cured, not erased, reversed. The decline that was heading toward dialysis had been interrupted. That is what happens when someone gets the right information before the window closes. Multiple randomized controlled trials confirmed that bariatric surgery produces measurable reduction in proteinuria and improvement in kidney function. Weight loss directly reduces intra-abdominal pressure, calms the RAS, and decreases glomerular hyperfiltration. The remaining nephrons stop being driven at maximum capacity. For patients caught early enough, function stabilizes and sometimes returns. That window exists right now for many people watching this video, but it closes quietly and without announcement. The 5 signs. Blood pressure that keeps requiring adjustment without resolution. Ankle and facial edema that worsens through the day. Waking 2 or 3 times nightly to urinate. Normal blood creatinine, but urine protein never tested. Persistent fatigue, post-meal nausea, and cognitive fog blamed on aging. Ask your doctor for 2 tests at your next appointment: a urine albumin to creatinine ratio and an eGFR calculated specifically using the CKD-EPI equation, not just a creatinine number. Write both of those down before you walk into that office. Your kidneys have been filtering your blood every minute of your entire life without asking for anything in return. They deserve to be checked properly, not just a creatinine on a standard panel and a reassuring smile. Properly. Everything I have shared today is based on 30 years of clinical experience and current published research. It is general medical information. It is not a replacement for personal medical care. Before changing anything, bring these questions to your own physician. Ask for the specific tests by name. You deserve a doctor who looks at the full picture, and your kidneys deserve to be in that picture. Take care of yourselves. I'll see you in the next one.